Welcome everybody to a live stream Hoag presentation of the acute stroke treatment and the impact of new clinical trials. I'm Dr. David Brown. I'm a neurologist and a stroke specialist. I'm the medical director of the Hoag Stroke Program. Tonight we're going to talk about what a stroke is, what the stroke symptoms are, how we treat strokes, and a little bit about the science behind why we treat strokes like that. And I'm also going to give you a window into the fabulous outcomes that we have at Hoag, which are truly world class. So let me just get started. We got a lot to talk about. So this is an artwork that my daughter, when she was a little younger, presented to me, and she was very proud, and I read it out loud. "Daddy, the best stroke doctor in the world." And then she said, "That's not what it says." But actually this is how the nurses see me, so that's actually pretty appropriate. But her artwork's gotten a little better over the years. So this is a little more representative of what she's doing now. So let's just jump into it. Ischemic stroke. So what is an ischemic stroke? Well, it's when there's a low blood flow to a focal part of the brain. It's usually caused by a blood clot, so acute therapy includes thrombolysis or clot busting. Secondary prevention of stroke depends on where the blood clot came from, the source of the blood clot. This accounts for about 85% of strokes, so that's kind of what we're going to focus on tonight. How important a problem is stroke? Well, it's absolutely massive. There are 795,000 strokes in the United States every year, resulting in about 4 million Americans living with neurological deficits due to stroke. At this point, stroke is the 5th leading cause in the United States. When I started here, it was the 3rd leading cause of death. So some of the things I'm going to be showing you have had a dramatic impact in that. Unfortunately, it's still the 2nd leading cause of death worldwide. Mortality from a stab wound is only about 5%, where stroke can be up to 20%. And it's not just a disease of elderly men. In fact, more women die from stroke than from breast cancer. Obviously, breast cancer is an important problem, but it's not just a disease of men. Probably most importantly to me, it's the leading cause of long-term disability worldwide. So if it doesn't kill you, it maims you and prevents you from living the life you want to live. But unfortunately, still only about 1 to 2% of ischemic stroke patients are treated with TPA, which is tissue plasminogen activator, or a clot busting medication, or other advanced therapies that we're going to be discussing today. So how do you know if you're having a stroke? Well, this is an extensive list of stroke warning signs, but basically, stroke symptoms occur depending on what part of the brain's affected. So that can be vision, or a sudden change in vision, or blurred or loss of vision, a sudden confusion or difficulty of speech, slurred or sluggish speech, loss of words, difficulty understanding words, sudden weakness, typically loss of strength in the face, hand, arm, and or leg, typically on one side of the body, but it can be both, sudden loss of balance or dizziness, difficulty walking or clumsiness, sudden change in sensation, including heaviness, numbness, unusual sensation in the face, hand, arm, and or leg on one side of the body, although it can be both, and sudden severe headache, or the worst headache of my life. Any of these symptoms are happening, you might have a stroke and you need to get attention right away. So how do we treat stroke? Well, the original treatment for stroke is something called TPA, which I alluded to earlier, or tissue plasminogen activator, which is a clot busting medicine that's injected into the vein that tries to break up the blood clot in the brain to save as much brain tissue as possible. This is the original study in the New England Journal of Medicine, and this came out on December 14th of 1995. So that was quite a while ago, but it's very difficult to do this type of treatment. You need multiple practitioners working in harmony and very quickly to give this treatment safely. So it hasn't been as widely adopted as we would like. Here at Hoag, we do a lot of it, of course. This is a cartoon of a blood clot. So this is our enemy. And what's a blood clot composed of? Well, it's composed of platelet aggregates, red blood cells, and strong, thin fibrin polymers, which are thin fibrous tissue. The TPA works on those fibrin polymers to break them up, to try to break the clot up. And when the clot breaks up, we restore blood flow to the brain, and we can save brain tissue. This is an old-fashioned slide that I love because it's taken from the original slide deck of the original NINDS trial that I showed you that recommended TPA was safe and effective treatment. But what it's showing us on the vertical axis is the likelihood of a good outcome, and on the horizontal axis it shows us time. And What it shows us is those patients treated early do much better than patients that are treated later. So when we're treating stroke, we're not just trying to treat within a time window, we're trying to treat that patient as soon as it's safe, as soon as possible, because we know that's going to result in much better outcomes. And this is what's going on in the brain when a stroke is occurring. So to the left of the screen, you can see that there may be a small structural lesion, or what we call the ischemic core, that happens very quickly because the brain tissue is so sensitive to damage. But there may be a larger surrounding area of potentially savable tissue, and we call that the penumbra. But as time ticks by, the ischemic core enlarges and the ischemic penumbra decreases to a point where there may not be savable tissue. After IV therapy came intra-arterial therapy, and 2015 was a very important year for stroke studies because 5 major stroke studies came out that proved that intra-arterial therapy was safe and effective. These were prospective, randomized, open-label, blinded endpoint studies, which basically that's a really high-quality study. That's what that means. And it proved that it was safe and effective to use both IV TPA in combination with these intra-arterial approaches. I'm going to show you what that looks like. Why were these studies effective? Well, they're using more effective devices, more modern devices, such as something called a stent retriever, which I'm going to show you what that is. They used imaging to confirm there was a large blood vessel that was blocked off. They also used imaging to estimate how large the ischemic core, that permanently damaged tissue, and how large the penumbra was, or the amount of savable tissue. They had quicker treatment, they used quicker treatment times and higher reperfusion rates, so it was more successful or more rapid. And they used full dose IV TPA treatment before they gave intra-arterial therapy, different than earlier clinical trials. However, this is very similar to the way we've been treating stroke for about the last 18 years. Things change over time, but we've definitely been on the cutting edge of this therapy, and these studies basically prove that what we're doing is right. And this is a retrievable stent. This one's called a solitaire. What you see there is it's inside a blood vessel in the brain, and it's snared that blood clot, and it's being pulled out of the brain. So this is what our protocol looked like in 2015, very similar to the protocols of these studies. We did a CAT scan or a CT scan, a CT angiogram and a CT perfusion, which I'm going to show you what that looks like. We've got no upper age limit for the patients we treat. Age is just one factor. We've treated a 107-year-old patient down to 17 years old. We want to help people do the best they can if they're functional, if they're a good candidate. Otherwise, we treat those patients. We use IV TPA, or the clot busting medicine, out to 4.5 hours since symptoms onset or last time seen normal. We were using intra-arterial therapy at that point only out to 8 hours because that's what the data showed us was a reasonable time frame. We're using IV and intra-arterial therapies in combination. Intra-arterial therapies in isolation, usually when a patient wasn't a candidate for IV TPA, and the most common reason was the patient didn't get to us in time, didn't get to us within that 4.5 hours. We had something called a penumbra catheter, which is a suction device. We had retrievable stents, like I just showed you. This is our CT protocol, and this is the protocol they ended up using for these studies, but we're actually early in publishing data on our experience with using this protocol. We have a CT of the brain, which basically is helpful for showing that there's no bleeding. A CT angiogram to identify a large blood vessel that's blocked off or a cerebral aneurysm. CT perfusion study to identify an area of brain not receiving adequate blood supply to help estimate that ischemic core and also the ischemic penumbra. So let's just talk about a patient. That make it very clear. So this was a patient who was 90 years old. He was independent for all activities. He was golfing. He was volunteering at a veteran center. He had some high blood pressure and high cholesterol, which is not atypical for stroke patients. He experienced a sudden onset of right-sided weakness, which caused him to fall. He didn't injure himself too badly, luckily enough. When we examined him, we found he had decreased responsiveness. His right face was weak. He had right-sided weakness. He could only look to the left, and his right side was very numb. And this was his imaging. On the top, we see a CAT scan. And what I see in that CAT scan is there's no bleeding. The bleeding would be bright white, and I don't see that. I also don't see a stroke, which is the most common thing when you do a CAT scan and somebody's having an acute ischemic stroke. But on the bottom panels, I hope you can recognize, particularly on the left side, that blue area is a large area of the brain not receiving adequate blood supply. And that brain's going to be damaged if that blood supply is not returned. On the right-hand side of the screen, it's a little more technical, but there's some very dark areas deep in the brain. Those are probably ischemic core. Those may already be damaged. But if we can save that large piece of tissue, even though the small piece of tissue is already damaged, that can make a remarkable difference in the patient's outcome. Now, this is the CT angiogram we do. Again, on the right-hand side of the screen, I think, is there a way for me to point? No. What we see there is the middle cerebral artery, and it's blocked off. That's because there's a blood clot there. And we get this information very quickly when the patient comes in. We take the patient to cerebral angiogram. They were an IV TPA candidate, so we've gone right to intra-arterial therapy. This is a cerebral angiogram, and what we're seeing again is that MCA is still blocked off, and that we know we need to open that. Following the therapy, I hope you can recognize the difference. Now this left MCA is not blocked off. There's a robust filling of that middle cerebral artery. All that blood flow has been returned to that patient. And here's a picture of the blood clot. That's what's been taken out. In reality, it's only about that big, but that can, change a life forever. On the follow-up MRIs, on the left panel, there's an MRI. There's a little white coloration, which is evidence of some damage. That's the ischemic core we saw. But I hope you can appreciate this tiny amount of damage compared to that entire side of the brain being dead from this stroke. And here's a video of what that looks like. This is a stent retriever procedure like I mentioned earlier. So just like this patient, we're going to focus in on the cerebral vasculature on the left side of the brain. Now we're looking at the carotid artery. A wire has been inserted into a blood vessel in the groin and threaded all the way up to the cerebral blood vessels. A catheter has been threaded over that, which is a tube. The wire goes across the clot. And now the catheter is advanced over the wire through the clot. The wire is withdrawn, and the stent retrievers fed up through the catheter and will be placed across the blood clot. As the catheter is removed, the stent intercalates into the blood clot, ensnaring it. In the carotid artery in the neck, a balloon is expanded to decrease blood flow through that area to try to prevent blood clots from being thrown downstream, and the blood clot's removed. So how did this patient do? Well, the next morning, they had very mild right-sided weakness, mild word-finding difficulties, but they had an excellent prognosis. We do 30 and 90-day follow-up phone calls for all of our patients, and what we found at that time was the patient was back to all prior activities, but he needed to work on his golf swing. So we had taken someone who would have been dependent for all activities for the rest of their life and got them back to their life, and that's our goal. In our data at that time, so this is in 2015, is something called a modified Rankin scale of 0 to 2, which means an excellent clinical outcome. At 90 days, we're achieving that after giving IV TPA in 74% of patients. That original trial that I showed you, they did it in about 30% of patients. So we're doing incredibly better than that. For intra-arterial patients, remember that got there too late probably to get the IV therapy, still 30% of those patients were being helped. And for combination therapy, 60% of patients were having an excellent outcome. So overall 64%, which is outstanding, with a very low symptomatic intercerebral hemorrhage rate, which is our main concern in terms of complications. So it's being done effectively and also safely. And this is how we compared at that time to these other trials which were so successful. And I think you can see, so we're all the way on the right. We were very successful even before this data came out, doing a similar practice style. And we had some of the best data that had ever been published. Quite good. So what are the conclusions from all this? Well, we can give IV TPA within 4.5 hours with intra-arterial therapy within 6 hours to be safe and effective. Quicker treatment times are associated with better outcomes. Using advanced vascular imaging, such as CT angiogram, is essential for patient selection for intra-arterial therapies. Imaging the core or the with CT perfusion may lead to better clinical outcomes and extended treatment windows. And using retrievable stents, or the most modern tools and techniques, are associated with faster, more successful recanalization and better outcomes. So basically, doing a better job at opening the blood vessel. And then came a new dawn. There was a trial called DAWN, and it looked at thrombectomy, intra-arterial, 6 to 24 hours after stroke with a mismatch between a deficit and infarct. So these are mainly wake-up strokes, which were a group of strokes that we couldn't really treat. And the reason is we need to use time criteria, which is taken from the last time seen normal. So if somebody was normal and they went to bed, at 8 o'clock and then woke up at 8 in the morning, we're outside of any treatment windows. But we felt that using imaging, we might be able to select some of those patients who would benefit from therapies. So using CT, CTA, CT perfusion, to identify the large vessel occlusion and the penumbra, as I discussed, they were able to treat patients and give them a functional independence of 49% for thrombectomy versus 13% of control, a massive difference. And importantly, there was no difference in symptomatic intercerebral hemorrhage or mortality, so it was also safe. Then a trial came called DEFUSE 3, which was called the thrombectomy for stroke from 6 to 16 hours with selection by perfusion imaging. Again, using these same advanced imaging techniques to try to extend the window. And using that in this 6 to 16 hour window, they found functional independence in 45% of patients in thrombectomy versus 17% of control. Again, a massive difference, and no difference in the symptomatic intercerebral hemorrhage rate. Another important factor is they looked at this treatment and the outcomes dependent on time. And what they found was there was no decline in treatment effect at later time windows. So that really opened up this new paradigm for us to use imaging-based patient selection for intra-arterial therapies. So this was the new treatment paradigm. Treatment based on imaging out to 24 hours last time seen normal. So this massively increased the length of time we could potentially treat a patient. Using CT, CTA perfusion to identify large vessel occlusion, the significant penumbra. We give IV TPA still out to 4.5 hours in patients who are a candidate for that, and intra-arterial therapy for patients with large vessel occlusion and a perfusion mismatch. So here's another example of how that was effective. This is a patient, this time only 46 years old, with a history of a low cardiac ejection fraction. In other words, the heart's not pumping very well. High blood pressure and high cholesterol. The patient woke up with dysarthria and right-sided weakness at 8 a.m., was last seen normal at 12 midnight. Brought to the hospital after the son noticed the symptoms not till 4 p.m. So this patient would have been outside of any kind of pre-existing treatment window. They had a CT angiogram and perfusion, which showed a left MC occlusion with a good penumbra. They received an intra-arterial thrombectomy, and symptoms significantly improved post-procedure. We used a scale called the NIH stroke scale, which was 13, which is a very severe stroke. But at discharge, it was 0. So the patient was effectively back to normal. Again, here's the perfusion imaging on the right side of the screen. What we can see is that middle cerebral artery stops abruptly and it's blocked off. On perfusion imaging, what I can see there is there's a large area of salvageable tissue. but also a large area that's being affected by slow blood flow. On the follow-up CAT scan, you can't really see any abnormality. Here's another example. 82-year-old female with a history of coronary artery disease, and she had already had an occipital stroke in January, and she presented in February with new onset of left-sided weakness, left facial weakness, and numbness noted upon awakening. So just the fact that she had had a recent stroke really limits how we can treat patients. In addition, the patient was 10 hours post last time seen normal. Again, previously a barrier. Using the advanced imaging paradigm that I've already discussed, we found a right MC occlusion with a significant perfusion penumbra, and the patient improved significantly after intraarterial thrombectomy. Her initial NIH stroke scale was 6, still a severe stroke, but this clot was a little farther out, a little more difficult to treat. At discharge, she had a 1, a very, very good outcome. This one's maybe a little harder. I usually point to these. I'm used to pointing to it. But on the right-hand panel of the angiogram, we can see on the left side of that panel, more distally, there's a blockage. But the interventional neuroradiologist was able to take the catheter all the way out there, pull out that clot, and give the patient a good outcome. And this is the MRI, which is very sensitive for damage. We can see these tiny little white dots of damage, but a large piece of the brain tissue was at risk when they came in. Now the patient had an excellent outcome. That's something that the more brain tissue you save, the more the patient can recover. So it's a new dawn. We're doing intraarterial therapy for patients last seen normal in less than 24 hours. We're using imaging-based patient selection, using CT angiogram and perfusion. We have excellent outcomes with low complication risk. So we're doing even better now. We've continued to improve over the years. So last year, again, a modified Rankin scale of 0 to 2, which is a good functional outcome at 90 days. For IV TPA alone, 87.2%. So compare that to that 30% of that original trial I showed you. Overall combined for all therapies, including the patients get IV therapy, intraarterial thrombectomy, or a combined IV intraarterial approach, 75.6% of patients who are getting these advanced therapies are having an excellent clinical outcome. So that's a major improvement over where we started. Just to show you how we compare, so on the left, this is for TPA patients. You can see that this is comparing us to other comprehensive level stroke centers, so only centers that give intraarterial therapy, which are the most advanced centers. We compare very favorably at 87.2 versus 67.4%. And then again, comparing all thrombolytic treatments, we compare fantastically compared to other high-level stroke centers across the country. I believe at this point we're in the top 5% nationally. So again, what do you do if you see someone with stroke symptoms, or if you recognize stroke symptoms in yourself? You have to act fast, and FAST is a mnemonic we like to treat to help people remember stroke symptoms. F stands for face. Ask the person to smile. Does one side of the face droop? Arms. Ask the patient to raise both arms. Does one arm drift downward, or are they unable to lift that arm? Speech. Ask the person to repeat a simple sentence. Are the words slurred? Can he or she repeat the sentence correctly? And remember time. If a person shows any of these symptoms, time is important. Call 911. Brain cells are dying. It's estimated that 1 million brain cells can die every minute after that blood clot blocks off that artery. Thank you very much.